Hello, good evening, guys. Welcome to the live broadcasting of Erufu, the online community medical support network. I am Shireen. Do you know that colorectal cancer is today the most common cancer in men and the third most common cancer in women in Malaysia? Today, we are proudly to be able to invite our Erufu healthcare partner, Dr. Shankar, the general laparoscopic and colorectal surgeons, to share about what is colorectal cancer. Welcome, Dr. Shankar. Hello, Dr. Shankar.
Yes, how are you?
Hi, I'm good. Maybe can say hi to the audience now.
Hi, everybody. Nice to meet you.
Before Dr. Shankar start his presentation, I would like to give a brief introduction of Dr. Shankar. So Dr. Shankar started his fellowship in colorectal surgery from 2013 to 2016, where he had his training in several government hospitals of Malaysia, and also had his overseas fellowship attachment for a year in the world-renowned Colorectal Training Center of King Chulalongkorn Memorial Hospital in Bangkok, Thailand. He is currently a board-certified colorectal surgeon by the Ministry of Health Malaysia. Besides clinical work, he has been also involved in academic training, and he has organized and also been a facilitator for various clinical workshops like basic surgical workshops, etc. during his time in servicing the government hospital as well. No more further delay, I shall pass the session to Dr. Shankar for his tonight sharing. Doctor, you may share the slide now. Okay, here to go.
Hi, everybody. A very good evening. Thank you for the kind introduction, Chen. First of all, I'd like to thank Erufu Care for inviting me today on this webinar to talk on colorectal cancer. Okay, I am a colorectal surgeon based in Pantai Hospital, Keroh, and my topic today is something very relevant. Is can't seem to. Yes, my topic today is I'm talk about colorectal cancer and what you need to know. Okay, as you all know, colorectal cancer it is the second most common cause of cancer death in Malaysia at the moment, and we're looking both in the men and women category, and in men it is the second most, if not the main cause of cancer death, and women is the second cause of cancer death. So in my practice, I see a lot of these cases alarmingly occurring in a very younger age group. So we are faced with this burden. So it's good to know for the public to know what is colorectal cancer. And here I'm trying to outline the management, the risk factors, and what you need to know to help you to understand colorectal cancer better. Okay, some hard facts about colorectal cancer in Malaysia. Based on all the statistics and data we have, translated into Malaysian individual, say for 70-year-old person, he has got a 5% lifetime risk of being diagnosed with colorectal cancer, okay, and 2.5 chance of dying from it. And our Malaysian average age for men is about 80 and women is about 85 years. So you die prematurely because of colorectal cancer by 13 years. This is the hard facts that we need to realize as Malaysians facing this colorectal cancer. Okay, from the Malaysian context point of view, like I mentioned earlier in my first slide, colorectal cancer is the second biggest type of cancer reported in Malaysia, second cause of cancer deaths in the country after breast cancer. But in men, colorectal cancer has superseded lung cancer as the main cause of death. Okay, so if you compare ourselves with our Asian countries, there is an increasing trend we see with regards to colorectal cancer. But if you look at our neighbors, Singapore and Thailand, they reach a plateau with regards to these cases, but we are seeing more and more of these cases occurring in Malaysia. So these are some of the statistics which I got for you to understand better. This is from our Malaysian Cancer Registry from the year of 2006. As you can see here, colorectal cancer is the second cause of cancer death in Malaysia at that time, and it still is. We are looking both in women and men. And in Peninsular Malaysia, 2006, it has superseded colorectal cancer among the male population. Okay, and look at the next graphic over here. If you look the three main races in the country, the Malays, the Chinese, and Indians, the Chinese ethnic group has got a higher instance of getting colorectal cancer. And this is also seen in the Chinese population in Singapore. When they compare the Chinese ethnic group against the Malay Indian, the chances of getting colorectal cancer among Chinese groups is very high. If you look at the statistics, 1 in every 37 males, Chinese males, 1 of them will get cancer, and 1 to 23 for females. Okay. So what is the burden of colorectal cancer in Malaysia at the moment? It has not economic burden. The government has got to spend about 108 million Malaysian ringgit to treat new cases from stage 1 to stage 4 in 2012. This data was got from the management of colorectal cancer in 2012, and we spent at that year about 108 million. This is excluding the other extra charges for the treatment for like biologics, which will cost roughly about 22,000 more for the stage 4 cases. So it's a lot of monetary involvement to treat this cancer. And 80% of colorectal cancer in Malaysia occurs above the age of 50 years. You may know that colorectal cancer occurs usually at the age of 60 and 70, but now we're seeing that occurring in a very, very younger age group at the age of 50. 50, you're still at your prime of your life. And if you have burden with this cancer, this is an economic loss, not to you, but also to the country. Okay? But unfortunately, patients in Malaysia, based on a study in 2005, they come for treatment at a very, very late stage, at stage 4. If you come at stage 4, the chances of cure is almost impossible. So that's the problem now. So what we need to do now is to educate people to come at a very early stage to treat this cancer. If you come at early stage, it is treatable. If you come at late stage, then everything's palliative for you. Okay, so since I'm based in Melaka, I took some statistics from the Melaka Cancer Registry. Our cancer data is not much different from the national data. Both the men and women colorectal cancer is still the second after breast cancer. Okay, and for the male population, it is the second after lung cancer. Okay, these are the data taken from 2011. And also in women, it is the number 2 after breast cancer. It is some idea per state if you look at, and I'm quite sure this data will not vary from one state to another. It almost more or less replicates what you see in the national data. Okay, so what is colon and rectal cancers? It is a disease caused by uncontrolled division of abnormal cells in the colon and rectum. That is what colon rectal cancer is all about. Okay, so how does cancer occur? Okay, generally in our body, there are cell divisions that occur in a very controlled manner. Why you require cell divisions? For our body to repair, to regenerate, to renew. But all is done in a very controlled manner. Okay, so but when it comes to cancer, this cell division goes in a very uncontrolled manner. You cannot control. And because it's uncontrolled manner, because of constant stimuli, constant exposure, these abnormal cells form. And this is how you develop cancer. And basically, the basic cause of cancers in the non-hereditary group are usually due to DNA damage and genetic instability. Okay, evolution of colorectal cancer. Okay, how does cancer occur? You don't wake up in the morning and you say you develop cancer. No, cancer, it is a multi-step process. It takes about 5 to 7 years for you to develop cancer. Start from something very small. You don't do anything about it. You don't detect it. It develops to becomes cancer. It takes about 5 to 7 years. Okay, so 2 main factors how cancer occurs is genes. We call one type of gene called the oncogene. This is the oncogenesis. It helps cell proliferation. I mean, it's pro-cancer. And tumor suppressor genes, the genes which prevents cancer development. Okay, so these are 2 main factors that the gene system that alters our genetic code for you to develop cancer. Like what you see here, APC and P53, these are tumor suppressor gene. And KRAS, it is a oncogene. So APC gene is what you say is initiator. Okay, any mutation in the genes that will start the ball rolling for you to develop cancer later on. So this is a brief understanding of colorectal cancer. It's very academic, but it's good for you to know. Okay. Okay. Okay, this is how cancer looks like. This is what you see in a normal colon, and this is what you see on your hand side. Is how cancer looks like from a colonoscopy. Okay, cancer by site. Okay, majority of cancers occurs on this. This is what we call the left side of the colon, from the rectum, sigmoid colon, and the ascending colon. It's almost about 70% of cancer cases in the colon and rectum occurs on the left side of the colon. Okay. So what are the risk factors for colorectal cancers? Yes, age is a factor, and the older you are, when you go 60, 70 years old, the chance of you getting cancer is always there. Okay. But does cancer really occur in the older age group? No, things have changed. This is based on an article from Star newspaper a few years ago. Colorectal cancer are striking in a younger age group. We are seeing more and more cases, alarmingly, unfortunately, the younger age group, in their 20s, in their 30s, in their 40s, developing cancer. Okay, so it's a multi-factor causes why you get in a very younger age group. But nowadays, it does occur in a very, very younger age group. Okay. Gender, yes, the male population are more prone to developing colorectal cancer because of their social habits, smoking, alcohol, obesity. These are all pro factors for you to develop carcinogenesis. Race, like I've said, the Chinese ethnic group, they are more predisposed to developing colorectal cancer. I'm sorry. So if you're Chinese, you have any abnormal symptoms, or you have rectal bleeding, loss of weight, or you're very anemic, and then you need to get yourself checked. Okay, obviously, like I said, these are all factors that cause colorectal cancer, carcinogenesis. I would say why, obesity, reduce the insulin sensitivity and stimulates the IGF factor, which are all pro-carcinogenic. Okay, smoking too, it changes the cells, acts on the micronutrients, and so it causes a lot of what we call in the medical term microsatellite instability, and these are things that causes to develop cancer. Excess alcohol, the acetaldehyde, these are very prone to getting cancer. Family history, okay, if you have family history of hereditary cancer, then it is one of the risk factors for you to develop cancer. Right? It's not a must, but it is a risk factor. So if you have a strong family history, then you have any symptoms, and you need to go for screening earlier for colorectal cancer. And your diet, okay, diet is the main factor now. You see why the younger generation are developing cancer, because the westernization of our diet. Our diet are full of fats, saturated fats, and also we take a lot of red meat. As you know, red meat has got a lot of iron overload, which are all pro-oxidants. That means what they do is they produce a lot of free radicals in our colon system, and these free radicals will react on our colon and cause mucosal inflammation, and you develop cancer. So if your diet is full of red meat, then it is not good for your colon rectum. Okay. So these are the foods you need to avoid. Okay. And these are the foods you need to try to eat a lot in your diet. Okay. Cause a lot of beta carotene micronutrients, which is required for the stability of our colon. Okay, and also for colonic transit time. A lot of activities, sporting activities, keep yourself fit, lean, healthy. Okay. Okay, I think this is a very important step. When you see a doctor, what are the symptoms that cause you alarming signs? Okay, rectal bleeding is one. When you have bleeding in your rectum, in your motion, you got to go see a doctor. And too much of mucus discharge in your colon, in your feces. You got to, sudden loss of weight, sudden loss of appetite. Suddenly, all of a sudden, past 2 months, you don't feel like eating. You have lost weight. Your clothes have become very loose. You have a lot of abdominal discomfort after eating. Altered bowel habits. Someone who's goes to defecate once a day, every day, suddenly sees itself defecating once in every 2-3 days. Or someone who goes to the toilet about twice a week, seems to be going every day. Maybe there's an alteration of bowel habits. It's something which you need to look into. Perianal symptoms like perianal itchiness, discharge, swelling, or if you any nodules, you need to go see a doctor. Tenesmus is one of the most important signs. What is tenesmus? The symptoms are you feel like going to the toilet. When you go to defecate or pass motion, you don't feel nothing is coming out. Or what you call in Bahasa Melayu is tak puas. When you go to the toilet, you come out again, and you feel like, I need to go to the toilet again. These are tenesmus symptoms. Constipation. Suddenly you become very constipation. You're very hard, straining stools very hard. This is constipation. Anemia. When you go for a blood test to your general practitioner, you see your blood test and your hemoglobin levels are low, say 8 or 9, but you have no symptoms. You look healthy, you're not passing blood, but why is your HB is low? There might be some occult bleeding from your tumor, and this you need to go see a doctor. And those advanced cases of colorectal cancer, you get all these palpable abdominal mass or anorectal mass. So these are the symptoms which you need to be aware of for you to go seek a doctor if you have these symptoms. Okay, is colorectal cancer preventable? Of course, it's preventable. If you come early, like stage 1, it's very curable disease. But if you come at a very late stage, then you got to go through a few more treatments. But that's still it's not very much curable as opposed to someone coming at a very early stage. Okay. Again, early detection saves life, which is very important. You need to detect early so that you can get early treatment, which is then your prognosis will be much better. Screening. Okay, what is screening? Basically, you do screening in an asymptomatic population, not in a symptomatic population. Asymptomatic population. Okay, so who do we screen? We cannot screen the whole 36 million nations. No, so usually we divide them into risk groups, low risk and high risk. If you're in a high risk group, say that you got family history, your grandparents, your parents, your uncles, aunties have got cancer of the colon, and then then you fall into the high risk group, or you have got history of inflammatory bowel disease or chronic colitis, then you fall into high risk group. And this group of people you need to screen, as opposed to patients who are in low risk group who has no family history, got no history of chronic issues. These are the low risk group. So when you want to screen the population, you need to risk certify them, and then accordingly you screen. So what are the methods of screening available in our country? We have stool examination, where we do the fecal occult blood testing, FOBT. Okay, radiological imaging, we do CT scan, it's mode of screening, and the most common one, the most important one, endoscopy, colonoscopy. This is the most important among the screening tools. These are the images from what you see in your colon, all the polyps, all the inflammations. These are the things you see. Okay. So, like I said, FOBT or fecal occult blood testing is one of the screening methods where you send a stool sample to, to any GP setup or NGOs where they check your feces for blood. Okay, but you have to be very careful now when you go for this test to make sure that you don't have any red meat 2-3 days before. Okay, sometimes any blood in the red meat, which might be translated in the feces, you end up having a false positive. You need to be very careful about it. But nowadays you have a newer types of fecal occult blood testing. You have the FIT, the M2PK test kit, which is more available in private hospitals and soon in university hospitals. Okay, endoscopy. This is called a colonoscope. Colonoscope is a fiber optic instrument where we use to visualize your entire colon, right, from your anus, rectum, right to your colon, to look for a lot of features in your colon, polyps, or any suspicious lesions where we can biopsy. So many patients have this phobia, going for colonoscopy is very painful. My friends tell me, very sakit, don't go. No, actually, when you go colonoscopy, most of the patients, they feel very comfortable with colonoscopy because they are very sedated very well. We give them a lot of sedation, we bowel prep them, enough sedation, they don't feel any pain during the process. So much so that when I finish the colonoscope, and the patient wakes up, they realize that, hey, I didn't know they did a colonoscope on me. So it is not as bad as what you think, colonoscope. Okay? And these are the images you see from a colonoscope. This is normal colon, it's inflamed, and this is the tumor you see, the polyps are trying to snare, any information at that time. But these are the real life images what you see in a colonoscope. Okay, and so when you do colonoscope, what do you see most of the time? Polyps. Polyps are the common things you see. So what are polyps? They're basically a benign growth which are seen in the colon or rectum. There are many types: inflammatory, hematomatous, adenomatous, and hyperplastic. So these are done based after reviewing the HP or biopsy of the polyps. Okay, and this is where cancer starts. From a very small polyp, you don't do anything, you don't remove, it stays there. 5 to 7 years time, you'll develop cancer. That's the idea of you going for colonoscope to identify these problems. Okay, approximately 90% of colorectal cancer arises from edematous polyps. It's basically from the mucoid glands of the colon. Okay, this is a classical picture of a polyp you see in the colon. Okay, the importance of seeing a polyp and removing the polyp makes a lot of difference, because studies have shown if you remove the polyp during a colonoscopy, it reduces your chance of developing cancer for almost 60 to 90%. It's very important. So that's the relevance of going for a colonoscopy, to remove this polyp and reduce your incidence of getting colorectal cancer so much higher. Okay, this is a CT scan where you go into a machine and we can visualize your entire abdomen. Okay, unfortunately, colonoscope, CT scan cannot identify any lesions which are smaller than 2 centimeters in size. Okay, but it's one of the screening methods of CT scan. Okay, and notice we have a virtual CT coronography where you can see the polyps, like a 3D view of the colon. Okay, it's a view of the CT coronography of the colon. This is what you see in the CT coronography. This is what you see in the real colonoscope picture. They're almost the same. Okay, in Malaysia, there are no actual screening programs in Malaysia in regards to colorectal cancer, as opposed like breast cancer, you have the mammogram. You don't have this. So the awareness of importance of colorectal cancer screening is very low, especially among the general population and policymakers. And because of this, we see a lot of patients coming at a very, very late stage. Okay, one of the reasons why they don't come for screening too is because of fear, embarrassment, and discomfort. And so time is an issue, because we are all a very busy nations. We have no time to go for all these important screening methods. Cost is an issue, and so access to infrastructure is another issue. Okay, and sometimes doctors don't talk about it, the importance of screening. So this is the scenario we have with regards to screening in Malaysia. Okay, the staging of colorectal cancer. Okay, what you need to do for staging. The most important thing is colonoscopy and biopsy. The biopsy will tell you whether the lesion you have in your colon or rectum is cancer or not. Once that is established, you've got cancer, then we do a CT scan for staging. It's very important. Okay, the MRI pelvis usually we do for mid and lower rectal tumors. We do for MRI staging to get a better circumferential view of the rectum. Okay, a PET scan where you scan from head to toe any tumor residues in the body. It's quite expensive, and very few centers in Malaysia has got PET scan. And the CA is a carcinoembryonic antigen, which is a protein in the body to use. It's like a tumor marker for colorectal cancer. Okay, so colorectal cancer, just like any other cancers, has got the sites of metastasis where it spreads. Okay, most commonly you see in colorectal cancer, it spreads to the liver, spreads to the lung, bones, and brain. Commonly you see liver and lung, the common sites of metastasis. Okay, MRI pelvis, like I said earlier, is meant for your rectal tumors. Okay, you got a colon, you got a rectum. Okay, you got a rectal tumor. If you come and see me, any patient comes to me, I usually subject them to MRI pelvis just to see the T staging of tumor, which will change my management. Okay, if you have a T2 lesion, then probably you can go for surgery immediately. If you have a 3T lesion, then I need to send you for adjuvant therapies. Okay, and MRI pelvis is also used for restaging of pelvic recurrence or pelvic tumor recurrence. Okay, so some of the images you see from the MRI, very clear, very defined. Okay, this is an endorectal endo-anal ultrasound machine in my clinical setup. This is my clinical room, and this is my ultrasound machine. I usually to see early tumors, T1 and T2 tumors, I use an endorectal ultrasound. Okay, these are the images you see over here. T1 lesion from the rectal ultrasound. This is a PET scan. Okay, I mentioned earlier it is a scan to detect tumor residues from any parts of the body, from the head to toe, basically. What it does is you're given a glucose-based contrast in the IV system, and tumors has got a tendency to absorb sugar. So when you inject this, then when you do the PET scan, any area that's tumor, they will absorb the glucose. That's how you know, oh, the area suspicious of malignancy. But unfortunately, you get a lot of false positives. But if you have any inflammation in your body, to say if you have a sore throat and you do a PET scan and there is an uptake in your glands to this contrast, then you might be worried that, or do I have cancer in my throat? So interpretation of this PET scan is very important. Okay, and you just don't go to a center to get a PET scan. Then you need to see a doctor for you to be assigned to go for a PET scan. Okay. So most of the time, when a patient comes to see us and we diagnose them for the first time with cancer, 20% of the time, they already got tumor spread to other places like in liver or lung. So it's this stage 4. There's 20% of patient who comes and sees us for the first time. Then the other 40% comes with a very localized disease at the area concerned, no spread anywhere, or spread somewhere else in the regional lymph nodes. Okay? So what they're trying to do is we're trying to convert this 20% that comes with the distant mets earlier. So you want more patients to come earlier rather than come at the very late stage. Okay, this is a brief outline on the management of cancer by stage. Every patient cancer is very individualized. Okay, you can't compare one patient's treatment to another. It's very individualized. So, but for a rough guide, if you come to stage 1 tumor, early stage, surgery alone is more than adequate. Stage 2, surgery alone, but depending if there is a lymph node involvement, you might have to go for adjuvant chemotherapy. Stage 3, basically you need to go for chemotherapy adjuvant. And stage 4, where your tumor has spread, your treatment is basically based on palliation, whether surgery is type of palliation or chemotherapy. And sometimes in rectal tumors, if you're bleeding, bleeding therapy is part of palliation too. Okay, minimally invasive surgery. I'm sure the audience must have heard about minimally invasive surgery, or what we call is laparoscopic surgery. It's nowadays we do things more laparoscopically, and tumors can be removed via laparoscopically or robotic assisted. And I do a lot of laparoscopic work in my hospital here, in Pantai Hospital, Keroh. It's very oncological equivalent as compared to the open traditional surgery. The benefits of minimally invasive surgery is, well, you have very small scars, very small incisions. Because of small incision, you have less pain. When you have less pain, you're able to ambulate, walk more. And then when you walk more, your bowel functions more, and then your length of stay in the hospital becomes shorter. And early return to activities. And overall, because your length of stay is shortened, the overall cost of staying in hospital decreases. So yes, it is a very good laparoscopic surgery, and it's one of the options nowadays we do for operating on colorectal cancers. Okay, this is a short video of early rectal tumor, mid-rectal tumor, a T1 lesion, which I did the indirect ultrasound, and I did a tennis procedure. It is what we call it as transanal minimally invasive surgery, where we did laparoscopy through the anus to remove this tumor. Okay, it is very graphic. What you can see in the center of this picture is your T1 rectal tumor. It was done through laparoscopy through the anus. So you can see I'm trying to define the margins, resect the tumor. Okay. I'm trying to get a clear margin, cutting it deeper. Okay. And once the thing is removed, then I'll laparoscopically suture the site. Okay. This only can be done for mid to upper rectal tumors, small tumors, early tumors, T1 tumors. By doing this, you don't have to have a colostomy bag. Okay. And this is a conventional laparoscopic surgery in one of my patients with rectal tumors. This is laparoscopically through the abdomen. So if you don't know what is laparoscopic surgery, it is a new way of surgery where we get access to the abdomen by placing pots and a laparoscopic instrument on video camera system to visualize the colon. So you can see here, I'm trying to dissect some of the structures. This is your ureter, which connects you to the kidney. I'm separating them from the tumor. Okay, these are the blood vessels and all that. Okay, this is I'm cutting the main blood supply to the tumor. Okay. It's a very delicate process. Takes some time to do, but outcomes are very good. This is me trying to dissect the colon away from the tumor. Tumors located in the rectum. What you see down here is down into the rectum where the tumor is. So you got to be delicate dissecting using the harmonic instruments we use. This going down right to the pelvic area. A lot of important structures are here, your vessels, your ureter. So this will be done carefully. Okay. So this is the beauty of the laparoscopy. So when you do laparoscopic, so you see the scars you get very small. This is the pot. This is where I put my camera. This is the pots I use of 1 centimeter incisions, and this is where I took out the tumor and the smooth. As opposed when you do a conventional surgery, the scar is so big. So managing pain, early admission will be very delayed. This is more cosmetically better and also oncologically also just as equivalent as open surgery. Okay, so when you do cancer surgery, this is the important structures. This is the tumor, the part of the colon, the mesentery, the blood vessels, sent to the pathologist. The pathologist would read the specimens and then stage them accordingly, and then to decide whether they need to be sent for chemotherapy or not. Okay, cancer treatment is not only surgery. You need chemotherapy. Chemotherapy can be given before surgery. Usually, we see in rectal tumors, it's called neoadjuvant. Adjuvant is after the surgery, and pelvic is meant for stage 4 disease where surgery is not viable for the patient. Then we have to pellet them with chemotherapy just to relieve them of the symptoms. Then radiotherapy, what we call it as current, we have external beam, you radiate outside the pelvis, or intraoperatively, like certain rectal tumors, we've got an intraoperative device where we do radiotherapy during the surgery. Okay. These are the 5 years survival rates for each stage of the cancer. Is colorectal cancer fatal? But if you come early, it is not. The chances of survival for 5 years, 92%, as opposed to you come to stage 4 disease where you got spread everywhere, your 5 year survival is only 5%. Okay. So my take-home message for today is the incidence and death rate of colorectal cancer in the country, though it is declining in some degree. Okay, my advice is to eat right, exercise, and avoid smoking. And these are all factors that stimulate carcinogenesis. Screening saves lives. Screening is very important, especially when you have strong family history of cancer. If you're in the Chinese ethnic group, you have all the symptoms which I mentioned earlier, then ought to go see a doctor or get a colonoscopy done. Okay. You don't have to wait for a doctor to come and tell you, oh, you need to go for screening. You need to know your symptoms, and then go and seek a doctor's help. Okay, and cancer treatment has evolved over the years, and the effects of chemotherapy is much better than as opposed to those days. So, because of advanced treatment, survival of patients from colorectal cancer also has improved. Okay, my presentation today is taken from the CPG guidelines from the Ministry of Health, Malaysia, the standard guideline for the management of colorectal cancer in this country. Okay, thank you.
Okay, thank you, Dr. Shankar.
I was clear and effective enough for you all to understand what is colorectal cancer all about.
Yep. Actually, okay. Doctor, you may stop share the PowerPoint.
Okay.
Okay. Okay. Okay, thank you, Dr. Shankar, and thanks for those that actually still staying with us. Now we actually open for the Q&A session. If you have any question, do drop us in the comment box below. So I start for my question first while waiting for the rest. Okay, just now Doctor did say that, mentioned that Chinese actually being the most likely to have developed this colorectal cancer than other races. So is there any reason behind? Is it because of the genetic or because of the diet or lifestyle pattern that have the Chinese developed the most common?
I'll go with the ethnic group first. Studies has done in the Chinese population in Malaysia as opposed to Malay and Indians, and also the Chinese population in Singapore as compared to the Indians and Malays there. The tendencies for the Chinese ethnic group to develop cancer is high. So we attribute this to genetic factors. Also, when the study was done in China, among the Chinese and Indians in India, the Chinese subgroup had higher rates of colorectal cancer. So yes, there is some genetic predisposition for the Chinese group to develop cancer. But with that, if you're Chinese, do you have to get colorectal cancer? No. You can't pinpoint one factor that can cause you to have colorectal. It's a multitude of exposures. Yes, family history of cancer is important. If you are in a Chinese ethnic group in Malaysia, you ought to go for screening if you have any symptoms. Also, there are other factors too to look at cancers, like your food you eat, your diet. These are the factors.
Okay. Just now, Doctor mentions that actually, Malaysia actually we don't have any screening tests for colorectal cancer, and we only can base on the symptoms that Doctor mentioned earlier to know that actually whether am I suspected colorectal, I need to go for further checking like endoscopy. Only we know, right? So is the symptom presented usually in early stage, or actually possible that the symptom presented the person already in a very late stage?
So with regards to your question on screening, yes, we don't have a regular screening programs in Malaysia because of colorectal cancer as compared to mammogram breast cancer.
Yeah.
But after saying that, there are a lot of NGOs who does this FOBT, fecal occult blood testing, and some gender practitioners do have this kit, but it's not done on a whole scale manner. It's very localized. So the access to it is limited. So we don't have that good of a screening, but there are in this country. Okay, question is, can colorectal cancer be asymptomatic? I mean, if there's very small ones in the early stage, it might not be symptomatic. Okay, but most of the time, the earlier ones are identified via investigations. Like what I'm saying is, say, if you go for the routine executive blood testing in the whatever labs they have in this country, suddenly you see, oh, your hemoglobin levels are low. Okay, your hemoglobin is 8 or 9. Then you ask yourself, I don't have any, I eat well, I exercise, why are my hemoglobin low? These are the alarming signs. You don't have the symptom, but it shows in the blood test. Because sometimes anemia is one of the presentation of colorectal cancers. These are the silent ones. The obvious ones were the late stage or stage 2, stage 4, when tumor becomes very big, then you become very obstructed, where you cannot pass motion, your abdominal or get very distended, or you tend to bleed. These are the late stage of the tumor presentation. So, but if you have got a strong family history, you should get colorectal bleeding. That's very then abdominal pain, sudden loss of appetite, sudden loss of weight. Then you ought to get yourself seen by a doctor and get a colonoscope as soon as possible.
Okay, there's questions from the live. Okay, hi Vicky. How soon we should go to the doctor once any of the symptoms show? For example, we might not thought of seeing the doctor if only constipation once or twice.
If you have constipation once or twice, then probably it's because you're eating during that period of time. So these symptoms is very prevalent, say 2-3 weeks, a month. these things you have to be alarmed. Once or twice in once or twice a day. I mean, just after you're okay.
It's quite general.
But it's very general. But but you have these frequent episodes, then yes, you got to go see your doctor. But if once or twice off, no, I wouldn't. But I will monitor myself. But if you're not sure, don't guess. Main thing, go see your doctor. Discuss the issue. Don't treat yourself. Don't assume yourself. It's better that you go see a medical practitioner and share your doubts, and we can let you know what's the real thing.
Okay. And okay, there's a second question from Bill. Okay, can detox prevent colorectal cancer? When they do, because like now a lot of people like to do detox program.
Yeah.
So is it one of the way for prevention?
I mean, a lot of people like to take all this detox in our body to cleanse our colon and all the stuff. Actually, it's not. If you do it for purpose, for colonoscope, or you do it once in a while, once in every 6 months, it is understandable. When you do once in every week, it's not good. You know why it's not good? See, in our colon, we have the good bacteria that preserves our colon. So when you take this detox, you wash away all the good bacteria and makes your colon prone to all these bad bacteria. So you need to keep a good bacteria in your colon. So frequent detox is not good. And you do frequent detox too, you will have a lot of electrolyte imbalance. So you lose a lot of sodium, you lose a lot of salts in your body, and that will affect your body system. Don't do it routinely. Like how you take your vitamins, don't detox your colon like that. To do it once in every 6 months, okay, but I wouldn't encourage that for my patients to detox themselves, because if you are having a lesion and you detox yourself, you might run into complications.
Okay. Okay, then there's a question also. What are the chances of cancer relapse after surgery or chemo?
For any cancer, whether you do thyroid cancer or breast cancer or colon cancer, the first 2 years after your surgery is the most important time for you to follow up with doctor, because these are the time where the recurrence happen. Okay, and depending on your stage too, or your stage of the disease at the time you go for the surgery. Okay, so the first 2 years you need to follow up regularly. If you do a colon surgery, you need to regular follow up with your blood test, CA, a regular colonoscope, regular CT scans. And it can happen. In certain aggressive tumors, they can have a lot of recurrence. But most important thing is, whatever cancer you have, you go for surgery. The first 2 years is the most important time for you to follow up with your doctor, because that is the time where the recurrence occurs.
Okay. Okay. Doctor, just now you talk about laparoscopy, but you do remove the damaged part of the colon, where you call a procedure called coloscopy, right? So is that always the option? Like just now you mentioned stage 1, actually patient also need to do a surgery. So is coloscopy is one of the surgery that for the stage 1 patients?
When you remove the colon, it's called a colectomy.
Colectomy.
So when you bring out a bag, we call it a bag, where you pass motion in the bag, it's called a colostomy. Okay, it's a colectomy and colostomy. So usually the right side of the colon, usually you do a colectomy and you don't have any bags. You just join inside the one. Only those tumors on the left side of your colon, the left side, if you come in an emergency setting, you will have a bag. And that bag too sometimes can be temporary, and sometimes can be permanent. Depending on where the tumor is and whether the surgery was done in an elective setting or emergency setting. Okay, so it varies. You can't say which is, but usually we on the right side of the colon is always a colectomy, no colostomy until certain conditions. And then on the left side, sometimes you have to do a colostomy, but that colostomy too can be temporary or permanent.
Okay, so usually after patients take that treatments, right? Or we don't. Is there any special diets that actually they need to follow?
because
Or
like
just like other cancer patients, how's the diet should be?
actually, because our colon, we are at the mercy of whatever we eat. Whatever food we ingest, the colon has got to bear with it. You eat good,
Yeah.
colon will be good. You eat bad, the colon system will be affected. So most of these colon cancers, after surgery, we try to advise them to go on a healthy diet. Don't take animal fat, saturated fat. Don't take red meat, like I mentioned earlier. Red meat, like beef, lamb, they have all this iron. Iron is a pro-oxidant. What are pro-oxidant? They produce free radicals in our colon and causes a lot of irritation in the colon. This is how cancer develops. So usually after surgery, colon, we advise people to take more of healthy diet. That means vegetables, greens, reduce the red meat, reduce the saturated fat, take a lot of fiber, and exercise. These are things we tell them to. They have to go to a more healthier lifestyle for them to recover from the surgery.
Okay. And okay, just relate on the diet. There's a question also. Because just now Dr. D, they talk about detox, then we will cleanse up. We also get rid of our good bacteria. So how about taking probiotic? Will that reduce the colorectal cancer, or after this, or even after patients got colorectal after the treatments, doctor's treatments? So is probiotic is good to also help them to come of
Yeah,
recovery?
probiotics are good. Probiotics are good. I usually give probiotics for my patients who got all infections in the colon. Infection, not cancer, infection, or colitis. After we do a colonoscope, diagnose them to have colitis, then I give them a course of probiotics for 2 weeks to stimulate the good bacteria to help the colon to recover. Okay. Usually we don't give probiotics for very long periods of time. Usually 2 weeks to 3 weeks we give. Okay. There are a lot of supplements or probiotics available in the market. You can take them. You can take them, but you need to be aware of what you're taking in the first place. But yes, probiotics does help in this treatment. Yeah.
Okay. Okay, I think for my last questions here, then we can end the sessions. How will the treatments actually affect patients' daily life? I mean, those patients that actually go through the treatment, will they able to work or exercise or perform their usual activity? Usually, what is the recovery period for them to get back to their normal?
You see, like for my cancer cases, if
Mm-hmm.
I operate them on a Monday, you usually get discharged on that Friday. Okay,
Mm-hmm.
if I operate them on a Thursday, they get discharged on Tuesday. That's the recovery time in the hospital. So at
Mm-hmm.
home, okay, they can't be going for jogging and running, and they can be mobile, but they have the recovery process because the wounds are involved for them to heal. It takes at least about 4 weeks to 6 weeks for fully the wound to heal. After that, they can slowly get to their normal walking, exercising, and all the stuff. But the first 4 to 6 weeks is where they need to recover, uh, improve their diet, get the energy back, for that the wound to heal. Okay, and patients who have a colostomy with the back, you'll be surprised that a lot of patients are walking around with a colostomy back, realizing they can be active in sports, you can be active in running. It's how you manage your colostomy. So having a
Oh, okay.
colostomy will not hinder your daily activity. You can continue your daily activity, but you need to know how to manage your colostomy. Yeah.
Okay, I think yes, there will be end. Thanks for doctors sharings and answer all the questions.
Thank you,
And
Chen. Thank
then
you for having me
yeah,
on your website.
yeah,
Yes.
good to any kind of last advice for the publics regarding colorectal cancer.
So my advice is colorectal cancer is the second cause of death of cancer deaths in the country. So we all are in this. We all are exposed to this. So be wary of your symptoms, whatever I told you. Be careful if you have any rectal bleeding, sudden loss of weight, loss of appetite. Go seek a doctor's help. Don't self-treat. yourself by Googling and then you treat yourself. That's the wrong thing to go. Go see, go see any doctors. Share your story with them because we are the experts. We know what is best for you. Okay, and if you have fall into the group of high risk group where you got a family history of cancers of the colon, you ought to go for screening as early as possible so that early detection saves lives.
Yes, good, great. Thanks, Doctor, for that. And thanks for the friends that are still with us. As what Doctor said, please do like the video tonight and share around to let all the people actually know what is colorectal cancer about and don't raise it and don't treat it yourself. Okay? Okay, now forget that we also have your page in Chinese and Bahasa Melayu, and do like and follow us. Before and end, I would like to inform that next Monday we are going to have aesthetic physicians, Dr. Alicia, to talk about how medical aesthetic technology can help us on what we can do on our face. For more information, please check the announcement post on your full page. The right clinic, the right doctor, the right care, the right information, the right knowledge, no panic, stay home. Good night, everyone. Good night, Dr. Shankar. See you guys soon. Bye-bye.
Bye.